like this, someone's always going to go to the opposite end of the dialect and bring up an extreme situation, right? That exists. Someone might be very manic. Someone might be
Sure.
aggressive, a danger to themselves or others, experiencing delusions or other forms of psychosis. And we do have to have a way to at least intervene medically in situations like that. But that's not what you're speaking out against. What are you speaking out against?
Yeah, probably the easiest way to come at this is, I'm not against drugs. I mean, drugs are drugs. There's a use case scenario for all of them, including things like ECT. From my perspective, what I'm speaking out against is how they're used, and so it's about the information that people hear about the drugs, and I guess how safe they are, and how little of a deal they think it is to use some of these medications. That's what I'm really speaking out against. I think there's just complete misinformation about the benefit and risk of these drugs, and we put people who have normal life problems on drugs that cause dependence and side effects and are gateway drugs to other things. I think it's just absolutely horrific. You may have seen another post I put out lately. I don't know, but I was talking about how we used to lobotomize people, and we look back at this barbaric time in psychiatry. But I see it happening now. I mean, the damage is far more wide now than it ever was with things we've done in the past. And I mean, that's how big of a deal I think it is, in terms of the overprescription and just the lies that we've told people about these drugs. So drugs are okay. There's a use scenario for all of them. It's how we use them. That's the problem.
Family medicine, primary care.
Mm-hmm.
I think statistics show over 80% of psychiatric drugs are prescribed in those settings. From your background, especially within the pharmaceutical industry, how have we evolved to a point where physicians who do not have expertise in this area are prescribing the amount of psychiatric drugs that they're currently prescribing?
Yeah, it's interesting. I mean, we've managed to, and this kind of goes to the open letter that you read at the start, where it's like we've convinced these family medicine doctors that, these are, well understood disorders, things like, diabetes, we're just going to be rebalancing the chemistry. And it's just like giving a diabetic some insulin. And so they go away and they say, oh, yeah, this is fine. I'll give them the scale, I'll give them the drug, and then we'll keep on tracking them. And that's all I need to do. It's fine. And if anything turns up, it's their underlying condition, and, it's not a big deal. I think if we were honest with our family medicine doctors and we really gave them the information about, hey, this is no small feat. I mean, we're messing with someone's brain chemistry. We're inducing emotional blunting. Sure, there can be a therapeutic element to that in some people, but there's also a lot of collateral damage that happens. I mean, you can really mess up someone's relationship. You can make them disinhibited. You can make people ignore their children when they're coming to them and they're having problems because they're too blunted to realize. And so I think if you start really giving people the information that they should know about using these drugs safely, I think some of them would probably opt out. They say, you know what? I actually don't have the time to oversee something that's this important and that has this many, potential consequences in your life. But yeah, we managed to convince them that they could do this work easily, just with like a scale, and so that's what I think has happened. And there's also been this big campaign where frequently we're telling everyone, depression, mental illness, it's underdiagnosed, undertreated. This is coming from really, really high up, from celebrities, from politicians. And so I also think they feel this almost social pressure that they need to go along with this because of all the messaging that they hear.
What I have a hard time with is trying to understand the mindset of a practicing physician, because this seems so obvious to me that you're providing a mind and mood altering drug, and sometimes to young people, developing brains, with pretty severe consequences. How haphazardly they prescribe this drug and minimize the risks makes no sense to me on how otherwise really smart people could make such errors in judgment. Take me into the mindset of the physician in Western society.
So, something that I think happens is a lot of these, this idea that drugs alter your brain chemistry, and that could be therapeutic or it could be negative, I think is the intuitive way that a lot of people think about just drugs in general, alcohol, cannabis, whatever all of that. That's how people come into it. I think we actually have a training system that makes people dangerous because instead of describing the drugs in this way, like it's a therapeutic blunting, and be careful about maybe some of the positive things it's going to take out in their life. We start telling them that that there's these biological things that are happening. The old one is rebalancing brain chemistry, but I see the chemical imbalance sneak in a lot of other areas. You'll often hear about antidepressants. They increase BDNF, brain derived neurotrophic factor. We're helping the brain become more plastic, and so we pull people away from a very correct and intuitive way of thinking about drugs, and kind of say, yeah, no, and tell them that there's like a brain problem. And so and so that's, if I go through the mind of a practicing clinician, that's what I think they're thinking sometimes. They're like, oh, maybe this is increasing the BDNF, because I heard this in a conference and it's really going to help them overcome some of the things. I think that's one rationalization. But the other one is like the whole like incentive structure, which we could talk about. I mean, we're not incentivized to really get people well in this, especially in the US. I mean, it's fee for service. I mean, if we can get, the more people we can treat in the less amount of time, that's how we get paid by insurance companies. And so, gosh, isn't it a lot easier to just have someone come in? Oh, I'm depressed, I'm sad. Option one is, tell me what's going on in your life. What are the problems you're facing? Let me really kind of get into that and understand it. And let's wait and let's kind of bring you in, a couple times a week for the next month so we can, so I can be there with you. That's one way of doing it. But the other way is, oh, you've hit threshold on the PHQ-9. We'll just try this medication. It's safe and effective. You just shut the whole thing down right there. And so I think there's, they've been misinformed, but also I think the incentive structure is set up where it's kind of easier for people to just, treat the depression like that and then, feel like they're helping them. But they're really helping themselves because it's just you can just check off the box. Oh, I've treated their depression and kind of move on.
During the opioid crisis, they had what was the pain was like another vital sign that when doctors, if they ignored pain, they could actually be under a malpractice suit. And it makes me think like that's what's happening right now in primary care settings is they're forcing every doctor to apply this PHQ-9. And if somebody comes up high, that might show that there's some depression, that to not do an intervention that they're only trained to do, which is to write a prescription, they're concerned that they could potentially have something come down on them if something happens to this client of theirs. It's a problem that I don't know if there's any solution for.
Yeah. I mean, I think, when you talk about screening, it's like, we could talk about it. Is this really a bad thing that we're screening people for depression in primary care offices? It's starting a conversation. Doesn't that sound reasonable? Wouldn't you want that, you to have a conversation with your doctor about depression? And it does sound reasonable, but the place where these screening instruments kind of fit in, it's part of a marketing campaign. And if you kind of walk through all of the steps, it's like, okay, first you have you got to convince the population that they might have a brain disorder or they might have depression. And so you go and fund NAMI, DBSA, all of these kind of groups. They go to the politicians and they say, hey, we're really suffering from depression. We need more resources. It's underdiagnosed, and you just hear it and it just gets hammered and hammered and hammered. And so people hear this in the news and in the media. They hear very favorable sound bites about medications. And so they go, okay, that's what this is. And then one day they're sad, they go to the doctor and they see the screening instrument and they go, okay, well, I'm going to fill it out. And the final piece of the marketing where it's like, why doesn't this lead to like a good outcome? It's just that, the medical literature has just been completely hijacked by pharma. And so, I mean, everyone who's ever been to a doctor and talked about a mental health problem, they know that person is not walking out of that family medicine appointment, with some comprehensive plan with counseling and social services and things like that. It's just not profitable. Our system's not set up that way. And so, when you've kind of rigged the system where it's just like very kind of transactional healthcare with just the dispensing of drugs, that's when all of these things kind of really take on like a sinister element, because like, is it really bad to fund, NAMI, to talk about the hardship of depression? No, is it really bad to do screening instruments? But when the end of that funnel is just drugs, and a lie about the cause of mental illness that makes people just want to take them, that's when things really get nasty.
And also add on to that, Sean, to your point, is the role of the major medical organizations. I had a conversation with a pediatrician. He's following guidelines from the American Academy of Pediatrics. And the American Academy of Pediatrics are very clearly, within their guidelines, minimizing the negative effects of an antidepressant for a teen. And they are overvaluating any benefits. If you follow the stream of money, they are funded by the pharmaceutical industry, biotech, and other conflicts of interest, which seems like there's a lot of shell groups that are just kind of developed through the pharma industry where people benefit from their stock, and they're nonprofits. And this doctor said to me, and I know I went into the guidelines. I'm probably one of the few people that actually read the background literature to support that guideline, because I know the literature pretty well. We've certainly had so many people on this podcast, some from the FDA, people who know the literature and some of the fraud that took place in the trials very, very clearly. They cherry pick studies. And now this doctor, this pediatrician who is dealing with a suicidal or depressed teen in front of him, he said to me, Roger, what am I supposed to do if that teen walks out of my office and ends up dying by suicide and I didn't follow these guidelines? I'm going to lose my license, even if I have concerns about the harms of an antidepressant drug. My license is at risk if I do not follow that guideline.
I think a lot of people feel that pressure that you talk about, when so much of the medical literature is stacked in that way to show the benefits, it's like that. But the thing especially with populations under age 25 on the antidepressants, it's like, everything has always shown that they increase the rate of suicidal behavior above and beyond, like more so than if you just gave them the placebo. And so it's just, I mean, the whole idea of like giving antidepressants to people under age 25 just seems completely absurd to me. I don't even know how, like why we accept that they have a marketing authorization for that. Like they lower depression on the HAM-D or the MADRS scale, or these primary, these surrogates for what depression is. But on the outcome that actually matters, like a suicide attempt, they increase the rate. And I want that just to like kind of sink in, really just like sink in for everyone listening here. You make more people suicidal under the age of 25 by giving them the drug. How does this have an indication from the FDA to use this? And it's, I think it's like mainly an American thing, because I don't think they do this in Europe. I don't think they do it in the UK. Actually, it's like an American thing that you can give these drugs to children with an FDA indication. It's insane. And I know I'm going to play devil's advocate. I'm going to jump on the other side and say, Josef, aren't there some people that you might want to do this cautiously with, if everything else didn't work, just knowing that risk and just saying you're going to monitor it? Sure. But if you're going to do that, I mean, it should be something like when you take Accutane because it causes birth defects, they make you sign a contract. Like we're talking about a level of risk mitigation that is, it's not just like your doctor can just say, I'm going to write you a script. They make you go and log on to like a database and like sign a contract that you really understand it. I mean, there seriously would need to be like that level of like awareness for the kid and for the parent. Like this drug could make you agitated and it could push you into suicide. Like it's So yeah, I mean, I think they're used like 1 out of 100 people under the age of 25 on these drugs, I think, should be taking them. I think the other 99, I think they've been completely misled. And then, yeah.
And that's where my anger is. And for people who see some of the things that I do on social media, why I'm so provocative, because I'm at a loss.